Yeah,
Dr.
you
Suresh, we
start
are
and
live
tell
now,
me.
sir.
Welcome to module number 18, which is going to speak about the AI in journal reading. How can you write? How can you synthesize the data? How can you analyze the data? How you write the articles? How you read the articles? To take us through, we have Dr. Yashas. But even before that, we have a very eminent personality waiting for us to speak about the most important aspect, that is ethics of publication. He is none other than Dr. Russell Dsouza. He is a UNESCO chair for the bioethics, and he has written enormous number of articles and publications, started this course across 5 continents. Dr. Russell, before Yashas starts, let us, a viewer, know what is the ethical aspect of publication, the reading and the science, being expert in the bioethics, to our new viewers in the era of AI. Over to you, sir.
Very good day to all of you there. I'm, as Dr. Suresh has just mentioned, I'm Professor Russell D'Souza, actually from Australia, but joining you from Buenos Aires in Argentina, where I've come for a meeting. I'm delighted here to see this, your current talk today. I think AI for smarter journal reading, evidence synthesis, and clinical learning. It is appropriate that we start with some thoughts on the ethics in publication. As you all know, publication ethics refers to the principles and the standards that guide honest, responsible, and indeed fair conduct in academic, scientific, and professional publishing, because it aims to protect the integrity, the credibility, and the reliability of publishing work. So, all of you are going to be talking about that, but there are 8 principles generally that we consider key principles in publication ethics. They are honesty and integrity, originality, um, proper authorship, and of course, transparency, the and respect for participants, peer review ethics, that's another area, and of course, avoiding duplicate publications, including what we call salami slicing, and correction of errors. But the common ethical misconduct that comes up is, and which all of you should be aware of, is plagiarism, data fabrication and falsification, duplicate publication, undisclosed conflict of interest, manipulation of peer review, and improper authorship practices. So, this is important that we have a consideration today to start with this important topic that you're going to take into account. We start off with an important aspect of ethics in publication. And of course, there are major guidelines and organizations that important promoting the publication ethics, and these are usually the Committee on Publication Ethics, the International Committee of Medical Journal Editors, and the World Association of Medical Editors. These are the important organizations and major guidelines and organizations that look at this important area of publication ethics. And now we are going to have your talk, so I think we can now understand that ethics in publication is essential for preserving the integrity, the trustworthiness of academic and scientific publications. Now, researchers, authors, reviewers, editors, and even publishers all share this responsibility for ensuring ethical standards are and making sure they are upheld throughout the publication process. I think, as an introduction to this topic that you're going to take today, on smarter journal reading, evidence synthesis, and clinical learning, I think we start with a very important aspect. I'm delighted that Dr. Suresh, who's your moderator, AVS Suresh, I had the opportunity of being with him a few days ago in Delhi. And a couple of days later, I'm away in another part of the world, but I'm delighted to join him today. And, and of course, I appreciate and thank him for seeing the importance of starting off with this little component. So, all the best to all of you in your program today, with, of course, the National Board of Exam and Medical Sciences, which I am also actively taking part in. So, Dr. Suresh, thank you very much, and we wish you best for today. I will stay on for a little while and take part in your program today. Thank you.
Thank you very much. These are the words of wisdom. So, the audience, he is a guy who started bioethics across the world more than 5 decades. Yashas, Dr. Nitin Yashas, please over to you for the proper class. And all of us, let's keep ourselves on mute. Thank you.
Right. Thank you so much, Dr. Suresh. You've been an inspiration to all of us young medical oncologists across so many years. Thanks a lot to the DNB board, the NBE, for giving me this opportunity. And it's such an honor and privilege to have Dr. Russell here today, and just to listen to such visionaries and pioneers in the field of bioethics is in itself a great learning opportunity. So today we are going to talk about how AI can be used for smarter journal reading. So what do we mean by smarter journal reading? So if we sort of look today, we have more than 1,200 papers being published every single time we open PubMed. The reality is we only have half an hour to 60 minutes per week for the clinician to go through all the latest updates. Now, most of the times as clinicians, perhaps we look at abstracts, we skip the methods. And what happens is on abstracts, we tend to make decisions based only on conclusion. And that sometimes can be dangerous. So today, over the next 40-45 minutes, I'm going to try to tell you how certain AI tools can be used, wherein in just 30 to 40 minutes, you are going to be able to improve your quality of reading of journals. You're going to become more scientifically astounded. You're going to have a more comprehensive backing to the clinical decisions you take, all in all, for better patient management and to become better doctors. Always, sometimes when we talk about research, there's always sometimes a stigma that research is only meant for those who are very academic. But we need to understand that reading journal papers is very important to transfer into clinical practice. Now, 2 to 3 decades back, the common refrain was, we do not have enough evidence to make good decisions, or we do not have access to evidence to make good decisions. But today, we have come to the complete opposite spectrum, which is we have far too much evidence to process. Now, the problem that we face in today's era of data is, how do we select good quality papers? How do we synthesize the information which is available in these papers, and how do we interpret it? I think AI or no AI, as a clinician, as a medical doctor, it all comes down to how do we interpret data, right? And that is what the next 30-40 minutes we are going to focus on. Remember that AI's role is not to find more papers, but rather to help make sense of the ones that already exist. Right? So this is the pattern that is followed. Like I said, we read the title, we read the abstract, drug X improved 90-day mortality or 1-year mortality. Oh, this must be fantastic. We then look at the journal and say, oh, it has been published in NEJM, JAMA, Lancet. This has to be a solid article. And our sort of critical appraisal of the journal ends there. But what is more important is that sometimes we skip the methods section. It may be we say, oh, it's too long. We don't look that the sample size was limited. It was an unblinded summary, unblinded study. And then we just go to the conclusion part and say, this is such a practice changing update. Let me start using it on my patients. And that indeed is dangerous. So how can we use AI for smart reading? At the outset, I would like to issue a disclaimer. I do not have any personal investment or any sort of advantages by recommending the AI tools. All these tools are being recommended for educational purposes. So the first one I want to talk about is something called asta.allen.ai. Think of it as your personal research assistant. Now, I'll tell you how you would be able to make use of asta.allen.ai. And the good thing about this tool is that it is completely free. So, as you can see here, it has three options. One is to find papers, one is to generate a report, and the third is to analyze data. So let's say you are in the ICU, you're an intensivist, or you're a physician, you're in the ER, you want to look at papers which have analyzed restrictive versus liberal fluid strategies in sepsis. So you enter that there, and it gives you how it is looking at the paper. It is not looking like certain other search engines at only individual lines, individual words. Now that may throw up a huge set of papers, which is very difficult to comprehend, and it may not be relevant to us. So it actually elaborates its thinking, and it says, to be considered relevant, the paper's content must satisfy restrictive versus liberal fluid strategy. It must compare or contrast, and it should be in sepsis. So it is narrowing down to make it very, very relevant to our search. It gives 74 papers, and the best thing is it also mentions, is it very relevant? How many people have cited it? And then you can also look here. It says what is somewhat relevant, apart from, of course, the age. So all along you may think, okay, fine, this is good, but this is not really great. What does this app have something extra? So like I said, one thing is it helps you get very, very relevant papers, because it makes sure that whatever you have asked, most of the papers stick to that, and it does not just throwing up papers which have done randomized control in sepsis. Now, when you want to generate a report, now you can generate a report either on a guidelines or a consensus. Even if you don't know what you want to generate on, it will give an idea. So as you can see, you can just type at, and next to it, let's say you type vitamin D. It itself will give you ideas on what you need to search for, or on what you would want to generate a report. So the moment I've typed at vitamin D, you can see it is looking at the Endocrine Society guidelines. It is looking at the latest consensus statement on vitamin D 2024. It is looking at vitamin D for the prevention of disease, and of course, epidemiological studies. So it itself is giving you ideas and guidelines. Now, suppose you're a postgraduate or you're a teaching mentor where you don't have any ideas for thesis, you can just type any topic here, and it will give you what is the existing paper which is already there. Now, this next part gets exciting. It is going to be able to generate a report. So imagine, let's take, for example, consensus statement on vitamin D 2024 guidelines, because vitamin D is making a lot of splash on social media and Twitter. You put that, it automatically gets the PDF of it, and now you ask it to generate a report, and boom, it generates a report. What are the key assessment points? That 25 hydroxyvitamin D is the accepted biomarker. Routine screening is not recommended. Targeted testing should focus on high-risk individuals. What are the health implications? So the entire summary of the consensus statement, now this entire paper might have taken you about 20 minutes or half an hour to read, but in a matter of 2 minutes, it gives you the brief nutshell. Now, always remember, and this is one of the most important themes of AI for journal reading that I must emphasize, never take it for granted. Always cross-check. So you might ask me, but Dr. Nitin, then I have to read the entire paper. No. So it has an option where you would be able to open the paper view on the right-hand side. And then when you click on one of the things that you want to be highlighted, it will highlight it in the paper and show it to you. So by that way, you're even cross-checking that there is no hallucination or that you're not getting an inaccurate thing. It is indeed coming from the paper. So let's say we are looking at the vitamin D regimen. If we click on this option of highlight in paper, you get in the paper where and what it is mentioned. So you're able to focus on that specific point you want more information on. Going forward, you could ask it anything about the paper. What are the details of the different testing and threshold? What is the rationale? What is the specific dosing for different population? So overall, if you have limited time and you want quick answers from a paper, we always suggest reading the full paper, but if you want quick answers from the paper and you want in short, a very quick, good, concise summary of the paper, Asta Allen is one of the ways to go. But you may think, okay, but what else is great about it? We know that you can use it to compare guidelines from one generation to the other. You can look at trends of changes in guideline. You can just ask it to generate a report based on the same. So for example, I asked what has changed in recent hypertension guidelines. And it again, remember, this is the generate report option in Asta Allen. In a beautiful way, it gives subheadings. What are the diagnostic thresholds and BP classification? How that was the change in the 2017 US guidelines? What are the treatment targets and when to start drug therapy? Diagnostic approach and monitoring. Remember, these review articles and journals can carry pages and pages, and sometimes we may get lost in it. Asta Allen does a very good job of keeping it concise and yet accurate. And it's also mentioning the sources, and that is very, very important again when we are talking about AI for journal reading, that we are ensuring accuracy and the ability to verify and cross-check. So let's say we click on diagnostic thresholds and BP classification, you can see the number of sources it has gone through. So it says under ACCHA 120 to 129 became elevated BP. But in contrast, the 2018 ES, that is the European guidelines, are retaining the older office-based classification. Why this mattered is simple. Lowering the cutoff changed who counted as hypertensive. So not only is it concising, it is also giving you a thought process that perhaps by the change in guideline, you're increasing the incidence of hypertension rather than perhaps a true increase or occurrence of hypertension. So remember, the one recurring theme through this is going to be AI to augment and not to replace. So wonderfully, it gives us all the resources which have been quoted, which we can click and go to the original article to sort of reference. And you have the ACC guidelines, the European guidelines. So in short, I would like to end by saying that Asta Allen is one of the tools that says that you can use it to generate a report on one particular article or a consensus statement. You can just type act and you can type some, you can type the topic and it will give you ideas on what are the papers around that topic. And of course, you can always use it to look at evolution of guidelines, and you can use it to search very relevant papers. So that is Asta Allen AI, and it's completely free to use. Now, this is a scenario that I faced. My HOD comes up to me and says, Nitin, I want you to take a CME on is immunotherapy beneficial in lung cancer? Or sometimes 5-6 years back, a patient would ask me, doctor, does immunotherapy really work in lung cancer? Now, without AI, I would just do a random Google search. I would look at, or a Google Scholar. I would get about 3 to 4 papers. I have the possibility of missing the negative trials. I may be biased towards more positive results, and I would have incomplete evidence. And again, there's a tendency to go towards the so-called reputed journals with a heritage, legacy, JAMA, NEJM, Lancet, without going through the details. But with AI, the beautiful thing is we will be able to stratify it as positive trials, negative trials, and which are inconclusive. Are they based on RCTs or observational studies and the other stratification factors? So if you do not already know about this app, there's this nice app called consensus. This perhaps is a reflection of my situation 6 years back. You have multiple papers which are printed out. You have the laptop open. You have a lot of sheets printed, more than 25 papers. You're looking for motivation. But what used to take hours or days now can happen in minutes. And this is the app. It is called Consensus. Now remember that when we are using consensus, what is very important is to frame the right question, because otherwise it will just function like any other search engine and just give you the list of papers. So you have to ask a question. So you can see here, is pembrolizumab beneficial in metastatic non-small cell lung cancer? Like I said, if you, I, or anyone uses Google search, we would look at 4 papers, 10 papers, 15 papers. This has retrieved around 1.3 million papers. Out of that, it has found 80 papers to be eligible. And out of that 80, it has included the top 20 to generate a consensus. So you can see that 83% of papers are in favor of pembrolizumab, that yes, it did provide a substantial benefit. There were mixed results in about 11% of papers and no in 6%. So it's very important to ask the question and then you get this consensus meter to say. Now, one step further you would go and you will get, where is this evidence coming from? So if you click below that, it will say that most of the yes is coming from large, high quality phase 3 RCTs with long-term follow-ups in top journals, 11 tier 1 studies. When you looked at the mixed results, it's just 2 papers, which are some systematic reviews and smaller RCTs, and the no, even though it is coming from 1 paper, we are aware. Why? Because we are seeing that it is in a specific subpopulation of lung cancer which carries a particular mutation where there is no benefit of immunotherapy. So just in 2 minutes, you have been able to get the complete picture of what 80 studies have been able to tell. And in that 80 studies, you are getting a flavor of how the evidence is behaving from the top 20 papers. Very important point, again, like I mentioned, to cross-check. You can look at what are the journals or the paper it has used, because it indeed cites them as well. You can see here when you click on it, you'll be able to get the number of papers. And then when you click on it here, you will get the journals. And here you can make a note. It's in RCT, it's in 2023, it's in meta-analysis, it's in Frontiers. And the no paper is a large human trial from Keynote 789 and is a highly cited paper. And you can click on it and go and double check from there. And not just 20 papers, you can download an Excel sheet as well, where it gives the link to each of those individual papers in case you want to personally read those papers, or let's say you want to read only the meta-analysis and systematic reviews. You can use those DOI or the links to go and read those papers. So very wonderful feature of this app. And it's just not the 20 papers you will be able to access. All the 80 papers which it has found relevant in synthesizing this evidence and report, you will be able to use in this app. So like I said, the 43rd paper was an observational study. The 44th is an RCT. And again, it gives a key takeaway from each of these paper. But again, remember, we are not using consensus to take key takeaways. We are using consensus to get a flavor of which side the evidence is going to based on a large volume of data done in different studies. So it's very simple other question. Is there a role of dual antiplatelets post-stroke for secondary prevention? It has looked at 5.8 million papers, found 84 eligible, and included again top 20. The evidence is more, but only beneficial in selected patients. And more importantly, again, like I said, it gives you the citations from which it has developed this. It also gives a condensed report where it says that 21 to 30 days has the best risk benefit, which are the special situations in which a longer period is given, all of this in the matter of 5 minutes. So what is the best way to use AI to read papers? So one, use an AI tool to summarize all 50 papers in one pass. Group them as either positive, negative, or inconclusive. Use consensus for that. I generally use consensus for that. Now identify the top 5-8 papers, right? Now again, like I said, consensus takes the top 20 papers. You can, from that 20, choose the top 5 to 8. Remember, there is a human involvement here. You cannot say that I'm going to leave everything to AI. So choose the top 5 to 8 papers, right? They could be large RCTs, they could be meta-analysis, there could be systematic review. Now, do a deep read of these papers. What do we mean by a deep read? You can upload these papers in apps such as Notebook LM or Asta LN. Try to nitty pick on what is the study design, the sample size, the endpoints, the methodology, and was there any blinding done? We will show you how to do these in the subsequent slides, and then try to lay your clinical interpretation to it. Always take certain aspects from the AI summary and check it against the original paper. That will help you ensure that there is no hallucination and that the numbers are matching, because if they don't match, that's a red flag. You need to stop using that tool then. And now using the AI structure with our clinical interpretation, we need to translate into clinical practice or use the appropriate conclusions for our research paper. So this is the workflow. A summary sweep, identify the top 5-8 papers, do a deep read of these key papers using AI, validate the AI summary by matching at least 3 numbers, and then build the synthesis. So how do we do a deep read of these papers? And for that, methodology is the most important. Like I said, conclusions sell paper, but it's methods which reveal the truth. So how do we do a critical appraisal of these papers? Very simple example. Reputed oncology journals said this drug reduced or rather improved overall survival in refractory myeloma, concluded that it should be considered for routine use. Should we proceed? What happened was, few months or year down the line, this drug was in fact withdrawn from its approval because the methodology showed that only 38 patients were used. So it was underpowered. It was open label. There was no blinding. The follow-up was less. The AI summary highlighted the OS, which was survival, which was not the primary endpoint. And of course, there were conflicts of interest. So just don't go by a AI summary to choose. AI summary is good, like Asta Allen would generate for guidelines, for consensus statements, but it is perhaps not really appropriate when you want to critically appraise a journal, or you want to sort of, look at, is this evidence practice changing? So how do we do that? What we need to understand before that is, what can AI extract from a paper? The sample size, the study design, the primary and secondary endpoints, the results with the p-values, the follow-up duration, inclusion, exclusion. But what it cannot is to detect subtle selection bias, judging if a surrogate endpoint is clinically meaningful, whether the population in the study is reflective of the patients that we see, and of course recognizing should importance be given to post-hoc analysis, and of course clinical judgment. So is there any app which can do this? One of the thing is called as Elicit. So what does Elicit do? So let us ask Elicit a question. What is the efficacy of exercise in reduction of occurrence of diabetes? Simple question that most of our patients ask, particularly in health checkups, wellness clinics, and to the endocrinologist or the physician. So when you type that in the box, it lists a set of papers and it gives a summary. Now it is upon us again to check the summary, because if you can see the first 2 papers, it is talking about improving glycemic control in patients who are already diabetic. So it is not really relevant to our study. This is where AI can make mistakes. Whereas the 3rd and 4th paper very much talks about the reduction of the risk of diabetes. But Elicit is not just to give a summary. One, I want to look at only recent papers. The first 2 papers were from 2006, 2007. So you click on filters here and you choose the publication date to be of more recent origin. You can choose the journal quality and even the study type. But why Elicit is very important is, in a tabular format, you can edit columns. So on the right side of the screen, you get an option called edit columns. There are some, based on the papers which it has already searched, there are some preset columns which you can add, such as exercise intervention details, efficacy outcomes and effect size, the study population and risk profile. So you switch all of them to on, and voila, you get wonderful table. So if you look at the first table, it shows that the primary outcome was HbA1c levels, which decreased. The intervention was compared to the control. What is good about Elicit is, unlike the regularly available LLMs, is it does not hallucinate. If something is not there, it tells it is not there. So you can see time points at which outcomes were measured were not mentioned. It also gives us a brief about what was the sample size, the study design, duration of follow-up. Everything that I talked about in the slide as to what AI can be used for deep reading of papers. The next study, you can see what was the type of exercise used. This study is a bad study because they have not mentioned really the primary outcome explicitly. The time points have not been mentioned. So you know that as a researcher, this is perhaps a study you should not be giving too much weightage to. Whereas in the third study, you can see the primary outcome was diabetic incidence, and that exercise plus diet reduced the risk with a relative risk of 0.63, and total sample size and number in each comparison arm were more or less same. So in a tabular format, you get everything which is needed to make a critical appraisal of the trial. Elicit goes one step further. This shows sometimes how much we have become dependent on AI, and sometimes we are outsourcing our thinking as well. So I typed a question: how does sleep affect glycemic control and diabetes? Elicit has an option where it can make the questions that we ask also better. So it says that it is a good research question. Consider adding these elements for better results. So it's like when we go with the first draft of our thesis topic or synopsis title to our guide, how certain changes are made and certain refinement is made as such to make sure it is better. So if I click on mechanism and scope, automatically it changes to a better question where it says, does improving sleep quality lead to better glycemic control and reduced complications in adults with poorly controlled DM? So you can see from this question how much more in-depth and detail it has made. And then again, it gives you the summary, the sleep intervention details, and you can make sure that just one glance at the papers or the studies which you're seeing right now, you know that these are observational studies. There was no intervention. You're basically looking at patients who had bad sleep and their HbA1c levels, and finding out that those who had a poor quality sleep as measured by this index had poorer sugar control as checked by HbA1c. So what would possibly take half an hour, 45 minutes? You're doing it in 5 to 10 minutes, not just by looking at abstract, but the entire methodology of the paper and the results section being distilled out in the form of a nice table. I hope if there are any doubts, you can mention in the chat box and we'll be able to take it up at the end. But this is my favorite part. How can we generate evidence and do evidence synthesis from the papers? Can AI help us make our interpretation better? Can AI help our thinking and cognition to also be better? All right. So these are some of the studies which you can see. So very famous RCTs which were there, which looked at how prostate cancer, the use of the different bone modifying agent. Now, one study said that denosumab was superior to zoledronic acid in delaying skeletal related events, whereas another study said there was no survival benefit over zoledronic acid. But remember, there are subtleties in this. Same drug, different population, different endpoints, and different clinical setting. And that is why results are diverging. But how do we know this, or how can we come to know this without going in depth to the paper? And that is where one of what I believe is the most important tool that can really revolutionize not just medical education, but any education and lead to personalized education, and that is Notebook LM. Notebook LM works on the Google platform and is integrated with Gemini. So when you open Notebook LM, either you can upload files. So you would have downloaded all your guidelines or the PDFs or the top articles. You can upload it here. You can even upload YouTube videos, or you can search on the web. The feature that we need to use here is something called as deep research, because the quality of search and the amount it searches is much better. So when I put in bone modifying agents in prostate cancer, it gives me at least 58 papers. And then I can look at each of these papers. I know it is coming from the latest updates. The American Society of Clinical Oncology is one of the landmark societies in oncology. You are using those guidelines. So we import all these onto the Notebook LM platform. Now, using Notebook LM, we can create PowerPoint presentation from all these sources. We can create a mind map which we can use to write exams better. We can create flashcards, infographics, but let us come to the data table option. So when we click on data table, we can choose the language, of course, and we can create a table of RCTs or meta-analysis in which denosumab or zoledronate have been used in metastatic prostate cancer. Now, I want to highlight, is it in a castration sensitive or a metastatic setting? What are the endpoints and what are the benefit? And then we click on generate. In 2 minutes, you get the entire table. Fantastic way. And the most important thing is it will stick to your sources. That is because of something known as RAG model, which is retrieval augmented generation, meaning it double checks and cross checks itself before giving the output that it is sticking only to the sources that we have asked. If, for example, you ask who is Shah Rukh Khan, it is going to say it is not mentioned in the sources. It is not going to go outside the boundary and give you an answer. So very clearly here we can see in a castration-resistant setting, denosumab was superior to zoledronic acid. There was no difference between denosumab and zoledronic acid in overall survival. Whereas in the castration-sensitive setting, zoledronic acid did not show any benefit either for prevention of skeletal complication or survival. So very clearly, upload all the sources that you want. Either you upload it yourself or you search on the web using deep research or Notebook LM, import it and create a data table. In 10 minutes, you get an amazing overview of the literature which is over there. Again, you can download an Excel sheet. Most important when we are using Notebook LM is we need to ask better questions. So this is the format that I would recommend for you. So if you're looking at just a single paper, you can give a prompt, summarize this RCT, include sample size, study design, endpoints, key result, limitations, and whether the conclusion is supported by the methods. Why this prompt is very important is it forces the AI to extract the methods and not just be a parrot and repeat the abstracts and conclusion. Now, if we want to compare studies, we can write compare these 5 trials, tabulate like I showed you before based on sample size, parameters such as HbA1c, follow-up duration, population and key limitation. Remember, comparison always works when it is given in the form of a table rather than a narrative which can sometimes hide differences. But we want to look cool. We want to be the Einsteins of research and research paper. We can look at doing a very good critical appraisal. What are the 3 biggest methodological weaknesses of this study? What biases might affect the conclusion? AI might, of course, find some of those methodological biases, some of the common biases, but we also need to augment this by taking these ideas and analyze ourselves. And lastly, this will be particularly useful for all first-year PGs. Your guide would be behind you, the board would be behind you to submit your thesis synopsis. You can upload a list of current papers and say, based on these papers, what patient groups are missing, what questions remain unanswered. All right. So these are the prompt templates which you should use, particularly in Notebook LM, to make it good use to ask better questions. But here's one very important secret I'm going to tell you. I'm going to teach you a technique now known as meta prompting. So what is meta prompting? Meta prompting is you don't need to think now of what prompt to use. You can ask the AI itself to give you a prompt, to use it back in the AI to get you the output. Almost sounds like Inception, but that is called as meta prompting. So you can see the latest American Association Guidelines of Diabetes has almost some 15-16 parts to it. I've uploaded all of them in Notebook LM. Now, as a medicine PG or a final year MBBS student or someone going to NEET PG or as a physician, I want to have a rapid study guide on what are the newer treatment options in diabetes and what should I keep in mind in OPD. Now, one way to do it is I'm going to think for 20 minutes as to what prompt, put everything, put a prompt, get an output, realize that something is missing and all that. But instead, I just go to ChatGPT and say, what prompt can I use in Notebook LM to give me a study guide on treatment approach in diabetes? It gives me a big prompt, things which I have not even thought about. It says, give me concise bullet points, memory tricks, tables, when to use what drug approach. And at the end, it is even telling, provide 20 Viva question, MCQ pearls and common clinical mistakes. So I just copy this prompt, paste it in Notebook LM into this, and then this is what I get. What should I use if a patient has heart failure? What should I use if a patient is having CKD? If weight loss is the priority? What is the memory trick for comorbidities to remember which drug to use? All of it in the space of 2 minutes, and again from a credible source. When you use it in a general LM, you do not know where it is coming from. But in Notebook LM, it is only based on the sources which you are giving, and in this instance, the American Society guidelines. It is giving us practical OPD prescribing tips, the top 20 Viva questions for students, which two drug classes have evidence for histological improvement in biopsy-proven MASH, what should be done when transitioning a patient from IV insulin to subcutaneous, how to prevent, all standard Viva questions. What are the common clinical mistakes we should not do? Starting metformin in a patient hospitalized with acute kidney injury, we should not do. Using a tight A1C in an 85-year-old. So in just 5 minutes, and remember, I did not even think of the prompt. I just asked ChatGPT to give me a prompt which I can use in Notebook LM, because the prompt which an AI gives is going to be much more informative and gives us what we want rather than we ourselves thinking. And in some ways, we always say we are even outsourcing our cognition. Now, what to do when you have to be in a journal club or do a critical evaluation of a paper using Notebook LM? So very simple again, just upload the paper, tell the notebook, I want you to critically appraise this trial, identify the methodological strength, crossover limitations, any biases, and how it is applicable to current practice. And again, it gives what are the strengths, the limitations, endpoint selection, was it good or not? And trust me, if you follow this, you can walk into any conference hall or journal club and you will be labeled as the cool doctor who knows a lot of research, right? Very important again, if you're seeing what Notebook LM is generating, it is back referencing to the sources which have been uploaded, which is why very important again to cross-check it. Thesis gaps again, a lot of GLP studies everywhere. So I said I want a prompt if I want to do a thesis on GLP-1 agonists. This is the extensive prompt that ChatGPT gave. I put it up in Notebook LM after doing a deep research on GLP-1 research agonists, and it gave me which are the underrepresented population. So then you can do a thesis topic of doing it in the South Asian population, long-term safety gaps and cancer-related outcomes, discontinuation and rebound weight gain. So it is identifying which are the research gaps, and it is even giving you thesis topic, prospective study to look at perioperative aspiration risk in GLP-1 agonists, novel adverse effects, sarcopenic obesity in elderly, or if you're doing some PhD level topics, to look at biomarkers. So upload all the articles or papers which are there regarding a topic, go to ChatGPT, give it a prompt that I want a prompt for Notebook LM to identify research gaps and potential thesis topics for the national board or the DM program, and it will give you. But this is something very, very important. I think both Dr. Suresh and the esteemed Dr. Russell Dsouza spoke about it. AI can hallucinate. AI can generate facts that look completely real. In fact, a few of my professors joked today, is it a real version of me speaking or is it an AI version? Because today you can even have AI clones and AI avatars. Remember, hallucination is not a bug. It is a fundamental property of how these large language models work. Most recent article, this was an AI generated image in any JM. So the quality or the reputation of the journal has nothing to do with it, but it had to be retracted because the authors used AI to modify the scale, and you can see the numbering is completely off. I think in today's newspapers it has come. This article was released on 15th May. More than 1,40,000 fake citations have been found in database just in 2025 alone. So remember, whatever AI says must not be taken as truth and gold unless we ourselves verify it. Personal example, I asked ChatGPT to give me a 500-page literature review on AI in healthcare in India with appropriate references. And then one of the references, when I asked it, it said, "You're right. I apologize for including a non-existent reference." This was actually Claude, not in ChatGPT. So I asked, why did you use a non-existent reference? And it just gave me that it incorrectly generated fictitious citations. It should have been critical to cite only real verifiable. It will create a new literature. So remember, this is not a bug. Even when you give a prompt saying use appropriate references, hallucinations can happen, fake citations can happen. This is something which has troubled even the courts and the judiciary where the case was dismissed and the lawyer was fined. It can sometimes give wrong drug trial results. And in a study where GPT-4 was tested on pharmacology questions, only in 23% of answers, it provided answers which were almost correct, but it was not. This is like some of us when we go to our Viva without any preparation and try to tell answers with full confidence. AI can hallucinate. So how can we pick up hallucinations? Remember one thing, most real studies are messy. They do not give definitive numbers like 50, 70, 100. It will be 36, 68. But if you're seeing too many perfect numbers, be suspicious. Look at references. If references have been condensed, always check, always verify the DOI before using it. If the AI says a drug works in all patients, be careful and go back and check because the study may have excluded certain vulnerable population. And if the AI highlights the secondary endpoint rather than the primary endpoint, again, it is a major interpretation error. So this is a framework on detecting hallucination and red flags. So how should we verify? Always check the DOI, verify the sample size, confirm the primary endpoint, check the population, and cross-verify key numbers like we mentioned before. Now, the last part of this is how can we use AI for content creation? Doctors are also becoming influencers, but I'm going to talk about how AI can be used for content creation, both from an academic perspective and more importantly, as doctors, we are teachers. How do we convey information to students or to patients? We need to use AI for structuring, for improving clarity, for a literature summary and abstract drafting. Remember, the responsibility lies with us. We are the final intellectual owners and not AI. So the same thing, American Standard of Guidelines. I now want to create an infographic, a poster to show how can we prevent diabetes. So I give it a prompt And remember, in Notebook LM, you can use analogies or similarities to make the topic explainable to patients. So I put, give me a poster to explain to patients how diabetes can be prevented. You can use analogies such as a nursery rhyme, cricket match. But because I was watching news at that point of time, I said, give it to me in the format of a war or a battleground. You can click standard here, you can type here, you can choose the type, English or Hindi. This is how it gave me. Such a beautiful creative poster. It says, deploy the scouts to identify screening to start at age 35 to detect pre-diabetes. Find out patients between 5.7 to 6.4. The primary mission is 5 to 7% weight loss. How? Doing 150 minutes weekly training, cut off the enemy's supply lines by using Mediterranean and low-carb patterns, enroll in a certified diabetes prevention program for lifestyle coaching, deploy heavy artillery, which is metformin or weight management modification if it is aggressive or high risk. Any patient will find this engaging, students will find this engaging, and at the same time, the critical aspects and the key messages are being conveyed. So this is how you can use AI to generate infographics. The Image Society, which is for the myeloma, wanted infographics to be created for patients. So this is for relapsed myeloma. We generated it even in Hindi, Kannada, Tamil, Telugu. But again, we have to make sure we take the ownership and check for it. Lastly, for literature review, my thesis topic in my MD was extrapulmonary tuberculosis and HIV. Of course, these tools were not there before. Again, upload all the papers that you want or do a deep research in Notebook LM, and then write a comprehensive structured literature review on the association between EPTB and HIV. Give it all the subheadings. More importantly, do not miss this line. Include proper in-text citations, and then you ask it to generate. When it generates, this was the literature review which I got. Clinical overview, global and regional epidemiology, clinical spectrum, risk factors. And again, you can see it is cross-referencing to the papers which have already been used as sources. So literature review based on 52 sources generated in 5 to 10 minutes. Remember, don't cut and paste it or copy paste it. Make your own changes, rework it to suit. Which is why rewrite in original words. Whenever we have used AI, do not use the AI as the source. Cite the original sources and declare AI assistant wherever required. Make no mistake, AI cannot be listed as an author because AI has no accountability, nor can it take responsibility. And always do not submit it without disclosure. It can lead to a very, very bad reputation and retraction. As reviewers, our responsibility becomes to verify all key references. We need to look at the methodology and not the writing quality. And always, whenever there is flamboyant language, too perfect a prose, overgeneralized conclusion, we need to be watchful and double check whether AI has been used and seek clarification from the author. As the editorial board, always run plagiarism and AI detection tools, prohibit AI as a listed author, and enforce post-publication correction. All right. We have the DPDP Data Act that is going to change the way we use a clinical data. We have to be sure we take ethics clearance, and going forward, we need to ensure that data collected for clinical care cannot be used for AI training without separate consent or consent waivers, especially if it is being done for profit motives. So what is the 5-step framework? Apply this to every paper. What is the clinical question? Is this question right for our patient? What is the study design? Who are the patients? What are the results? Does it apply to my patient? Question number 5, only we can answer it. AI cannot. AI is very good for the first 3 and to help us interpret 4th, but the 5th question only we can. Remember, like I always said, AI is to augment, AI is to improve our cognitive skills. when we look at the methodological bias, when we look at the limitations that AI tells us in a paper, we start thinking more. And that's the way AI should be used for speed, structure, pattern recognition, whereas we need to look at the interpretation, the clinical context, the ethical judgment, and the bias detection. So without AI, what happens? If we look at the surviving sepsis guidelines, I will say the hour one bundle reduces mortality. I look at it for 2 minutes. I assume it is in all sepsis patients, and I start applying it to all patients. But with AI, I generate a summary. I look that what is the method, what are the protocol violations. I take 12 minutes for it. I look at 3 key sections. I observe that the bundle works in high resource setting and that the fluid strategy varies by renal function. The population excluded dialysis patients, pediatric and immunocompromised patients. And now I decide to use it only in the eligible patients. So from 2 minutes to 12 minutes, but with much better understanding and clinical applicability. So at the end of this program, how can you use this 40 minutes to look at deciding how to read a paper? Just use this 40 minutes either daily or per week, depending on what your time. Do a 5-minute AI sweep. Give me 3 bullet summaries of these 10 papers. Flag any with sample size low or surrogate endpoints. Now, out of those papers, you identify what are the 2 or 3 must-read papers. Upload those papers into Notebook LM. Ask it to give you a critical appraisal or to give you a methodology, or for example, to do a debate. Tell it, give me 5 points in favor of early dialysis, give me 5 points against late dialysis, and then you start thinking more. This is non-delicatable. You have to use it. From whatever comes, check at least 3 numbers with the original papers to make sure there is no hallucination, and then ask, can I apply it to my patients? So in just 40 minutes, what used to take more than 1 week or 2 weeks, you are able to summarize. AI sweep of papers with a summary, shortlist and classify important papers, do a deep read using Notebook LM, verify 3 key numbers and what can be applied to the patients. Remember, AI is a filter, not an authority. Methods are more important than conclusion. Hallucination is real and dangerous. AI sharpens thinking. AI augments us. AI does not replace us, and integrity is always there. So with that, I would like to end my talk by saying that read faster, write faster, and search faster AI will do, but it cannot take clinical responsibility, nor can it apply it clinically, nor does it know our patients. So with that, I hope this has been an informative class, and once again, I'd like to extend my heartfelt gratitude to the NBE board and Dr. AVS Suresh for giving this opportunity.
Such a wonderful lecture. We have close to 600 questions. I just try to sum them up, and then let's see between us, we'll answer it. You can just stop the presentation.
Need to make use of AI to filter those
Yeah,
questions.
exactly. I did the same thing. Are there any free plagiarism checks and AI checks? You already answered yes, they are there. So there are websites that can tell whether it's AI written or human written, right?
Absolutely.
So can you give some examples? Grammarly or something?
No, so there are a lot of AI generated checks which can be done. But I recently came across one article where someone uploaded one of Shakespeare's plays, and that was also flagged off as being AI generated.
Oh, that's not surprising.
We need to be circumscribed even with usage of AI generators. But I think with scientific articles, like I mentioned, usage of very clean numbers, lot of flamboyant and verbosity, grandiosity. I think even as humans, when we look at it, we will realize that these are AI generated. But if we Google it, there are a lot of AI generators that can be used. Grammarly is one of them. There is Quillbot. There is something called as Zero GPT. There are also those which can convert AI generated to humanized. So they are called as humanized AI. But then that's, of course, a completely different topic.
Right. So is the illicit free?
Elicit does work free, but the features are very limited. With a paid version, one can even do systematic reviews as well. So with the free version, there are limitation to the number of columns, the number of the papers that can be uploaded, and of course, downloading it in an Excel format.
Right. So can you apply your manuscript to AI tool, and can I apply it as the author, as a reviewer? You are never supposed to do till it gets published. So that's one advice I can give on behalf of patients. Do you agree, Nitin?
Yes, sir. As a reviewer, we should never ever upload any other author's manuscript into AI as such, because we have not taken consent and it is not right. And I think we should be functioning our duties as the
Right.
reviewer.
And as an author also, you should use your I mean, you can't depend 100% on the AI to
Absolutely.
help.
We just need to use it to fine tune and sort of give us inputs to start the first drafting process. But the final draft should always come from our side.
Right. So two questions. Will the Cochrane reviews and meta-analysis will be a past, or you will start seeing every next minute?
No, that's a very difficult question, sir. I think it also comes down to motivation. I thought I would be writing papers left, right, center, but it has still not happened. No, I think it again comes down to the ecosystem and how much of research we can encourage. I think definitely we are going to see an increase in the number of meta-analysis and systematic reviews, but I don't think the legacy Cochranes and all are going to be a thing of the past, because again, AI is augmenting our search of these databases and not replacing them.
Right. Sir, this is perfect. Dr. Russell is there. I think he's logged out. So, any final comments, conclusions? Because I can't read all the questions.
Right. No, I think you can write to us. You can, of course, find us on LinkedIn or Twitter and reach out to us for anything which we would be able to help. But I would always urge all students at this opportunity that do not take research as something which is overwhelming and burdensome. I think it is always associated with negative connotations. With the use of AI, you can make research fun. Like I showed you, you can ask it to explain any research articles in the form of a cricket match, a football, a F1, and really go into the depths to understand it. Because again, remember, even if you're not publishing papers, it is very important to understand research well to decide how to use it in patients better. And I need to be thankful to my teachers and mentors, even during my oncology training and internal medicine training, where anything was discussed and debated at the bedside and why we should make a clinical decision for that patient. And that is what is important. And that is what AI is going to help us understand these research papers better. And like I said, meta prompting. We now don't need to think too much about making a prompt as well. Use the prompt to get the best outputs from AI.
Wonderful. Over to you, NBEMS, for the conclusion remarks.
Thank you everyone for joining this session. Thank you. Thank you, sir.
Thanks a lot. Bye.